So I have received the question, what impact does trial eligibility have on generalizability of survival data? My name is Tarec El-Galaly. I'm a professor of hematology at Aalborg University and Aalborg University Hospital. And I'm going to talk about an abstract we presented at ASH this year. It was presented by our medical student, Freja Severinsen, and co-authored by Freja Severinsen and Laura Morse from our department. This inspiration for this study was actually a study going out of the Mayo Clinic some time ago that showed that patients with diffuse large B-cell lymphoma that didn't match organ eligibility criteria for a clinical trial did much worse than the patients that actually did match the clinical trial eligibility. And this was based on the real-world data from the Mayo Clinic. And this was also evident in terms of lymphoma specific survival. So it's really clear that patients that are eligible for clinical trial probably just have a better prognosis. They are able to wait longer for treatment. They have better organ function. And inspired by this, we wanted to do a similar investigation in our Danish data, because this question is becoming ever more relevant, because we are becoming more and more aware of in the lymphoma community or in hematology in general that clinical trials are not representing the broad patient population. They are very selected in terms of better health, even better socioeconomics, and probably also selected centers where they have greater experience with treatment. We used our Danish lymphoma database for this, the LYFO database. This is a very good population-based registry that covers all lymphoma patients in Denmark and have a very good coverage also on a lot of clinical variables and a good data accuracy. And we used this to look at the trial eligibility criteria for 4 different trials. We used the H184 trial, the Goya trial, the Polaris trial, and the Remodel B trial. These are all common trials, large phase 3 trials in lymphoma. First, we matched the patients on something we call high-level trial eligibility criteria. And this was the trial eligibility criteria, such as if they used a specific age category, for example, 18 to 80 years old, or if they had specific requirements for IPI or disease stage, so that we knew that what we were comparing were patients more or less in the same age category and same disease risk group. But after this, we also looked at the organ eligibility criteria in these subgroups and matched the patients according to if they, assigned the patients as being eligible or non-eligible based on, for example, thrombin counts, creatinine, liver function, and neutrophil count. And what we saw was that actually around 20% of the patients were not eligible for the trials. And when we looked at the outcome of these trials, we saw the very same as they reported from the Mayo Clinic, that patients that do not fulfill trial eligibility criteria actually do much worse. And this difference remained even when we adjusted for the residual differences in, for example, age or IPI score that could be after the initial selection. What I think especially interesting about our data this Congress was that we also looked at the control arm of these clinical trials, and the control arm of these clinical trials were all R-CHOP, which is still the standard of therapy today. And we looked at how the control arm did in comparison to the patients from the real-world cohort, from the Danish real-world cohort that we assessed as being eligible for the trial. And what we did see was actually that the differences was minor between the control arm of the clinical trials and the real-world patients. And this has some potential implications, because there's a growing interest in using real-world data as external controls for clinical trials. And this has the reason that we are seeing an increasing number of drugs in hematology today being tested in single-arm phase 1-2 trials, and after that maybe receiving a regulatory approval. And sometimes after this, we really miss some good comparators, some good understanding on how these patients actually do in comparison to what we could expect with normal therapy or standard therapy as we have it in the real world. And therefore, knowing that we can actually more or less match outcomes from real world patients to clinical trial patients is really encouraging, because we can probably in the future use these data more and more for assessing the outcome across different trials, across different treatments that were not compared head to head in a clinical trial, but need some external data. And I think a very nice example of this was actually presented at this year's ASH by Dr. Novakovsky from the Mayo Clinic, that showed that they could do a quite nice matching of patients that received tafasitamab and lenalidomide to a number of other therapies, and really add data on how this therapy did compared to other treatments that they were not that was not even compared in a head-to-head trial, but just using external data. I think we'll see much more of that in the future, and this will be very important for us when it comes to informing which type of new treatments we are going to use for different patients, but also when we want to ensure that the treatments we implement in the real world setting in the daily clinical practice based on very selected clinical trial actually also are associated with an equal clinical benefit to the patients that are treated in the real world setting.